good afternoon, dear ladies and gentlemen. A wonderful welcome from Vienna here on the 5th of December in the hearing group to our quarterly hearing roundtable. And for us here in Austria at the 5th of December, it's a very important day. It's the day of Krampus. And if you do not know what the Krampus is, look in YouTube under Christoph Waltz and Krampus, and you will enjoy. But to hear the Krampus correctly, you need bilateral hearing. And this is what we're here for. So welcome to our hearing roundtable. You can look at all the other roundtables already in YouTube. And now some words about the hearing. The hearing was founded in the year 2007, so we're still quite young. And we are now together over 30 ENT departments all over the world. And we are very proud of this. We want to serve you. This is our group photo from the last hearing meeting just recently, 2 months ago in Dubai. It was hosted by Professor Abdurrahman Hajra from Riyadh. It was a wonderful meeting. And you see us together. We are not only medical doctors, we are not only surgeons, we are engineers, audiologists, speech therapists, basic science, electro engineers, and we want to serve the patients, to do the best for the patients and also for you outside there to give the best benefits of research in implantology and otology to our patients. We're a global network, 33 departments on all continents, and we work comprehensively together. And we are innovating, we are coactive, and we are educating also the other people. And we have a lot of white papers and some papers out in the Medline. Every year we publish about 15 to 20 papers together for research in cochlear implants. And we have different standards already since 28. And this is an interactive meeting. So please, you can chat with us. You can raise your hand if you have a special question. So we will moderate. We have an outstanding moderator, Professor Javier Gavilan. He's very, very famous about this. The meeting will be recorded because you will see us later on for years, for many years in YouTube, I hope so. And we talk this time about bilateral hearing. We had already a wonderful session about bilateral hearing some time ago, but there was so much to say, so we decided to be a second time. So moderator will be from the University of La Paz, Professor Javier Gavilan from Madrid. And we have a wonderful lady professor now, Andrea Overton from North Carolina. So it's not only Professor Kevin Brown, who will also join us. And then from Chennai in India, Professor Ranjit Rajeshwaran, very, very nice. And of course, our last host from the hearing meeting, Professor Abdurrahman Hajra. He also recently wrote an outstanding book about medical doctors in airplanes, but this is another story. Now, please enjoy the meeting. We will be all together, and I hope we all learn a lot about bilateral hearing part 2. Thank you.
Hello, everyone, and thank you for attending the last edition of our Hearing Roundtable program in 2024. As many other online activities, this roundtable program started during the pandemic when online meetings were the only way to communicate. And once the normality was recovered, we realized that this was indeed a very good tool to keep in touch with the international community, and the hearing group decided to start this periodic online roundtable program. As Professor Baumgartner mentioned, today's roundtable will deal with bilateral cochlear implantation. And we have a question for that. If we double the sound, do we also double the benefits? Well, let's see what our experts say. We discussed this topic, this was also mentioned by Baumi, on a previous hearing roundtable this year, 6 months ago, And we had such a good acceptance of the topic that we decided to have a second edition on the same topic, and here we are. We'll probably all agree that two CIs are better than just one, but some controversial issues are still present in the world of hearing rehabilitation concerning bilateral cochlear implantation, and we will try to deal with them during the next 90 minutes. The questions about the optimal and last possible time to go bilateral are repeatedly showing up and seem to remain unknown for the majority of us. This is indeed not easy to answer as the subject groups and the outcomes differ. So we need to have more information about this. Economic issues related to bilateral implantation are also a crucial issue, especially in emerging nations, and we will deal with this also in the next minutes. And we will also deal today with the psychoacoustics and the audiological considerations of bilateral cochlear implants. And finally, the use of local anesthesia for simultaneous bilateral cochlear implant in adults with same-day fitting will be a breaking proposal by Professor Hager that will be discussed during this roundtable. We hope that the combined experience of the hearing members may increase our knowledge about the best clinical practice in bilateral cochlear implantation. And for that, we have a distinguished group of audiologists and surgeons that were mentioned by Professor Baumgartner at the beginning that will deal with different aspects of bilateral cochlear implantation in a multidisciplinary environment. We have surgeons and we have audiologists, and in the audience we have more opinions. And as we said before, this is designed to be an interactive session. You can ask the speakers by raising your hand in the chat of your Zoom application, or just by directly going on the microphone if you want to do it. Just ask for permission and we'll turn on your microphones so that you can also ask your questions. But you can mainly use the chat, which is easier for all of us. And I will try to bring the opinion, the questions, and the comments from all of you to the experts of the hearing group as long as it is possible. And to demonstrate that we really want this to be an interactive session and we want you to participate, I would like to ask you to switch on the camera of your phone. Please take your phone and switch on the camera of your phone to scan this QR code that we have on the screen. Or if you don't have a camera, you don't have a phone by your side, you can go to internet and you go at menti.com and use the code that you have here. You enter menti.com and use 5329-8005. And you can answer the first question, which is, what is your field of expertise? You just turn on your camera and tell us you're a surgeon, you're an audiologist, you work on rehabilitation, you're a student, a medical student, or whatever you are. Just tell us. We want to have an idea of the audience that we have. Right now, we have more than 70 participants, so we need to have more information than the one we have here. We already have like 8 or 10 answers. Need some more answers from you. Remember, we want you to be participating actively in this roundtable. We have pediatric audiologists, neuroscience, cochlear implant, project management, audiovestibular medicine, a lot of different approaches. Majority of the audience seems to be audiologists. So it looks like the surgeons, we are not so many today. Surgeons are somewhere around here. It's not that many surgeons. Again, it's mainly otologists, pediatric audiology. Okay, so we have a fairly large number of different fields of expertise. And now let me ask you the second question. The second question is, which country are you connecting from? From which country are you watching us right now? Again, the same connection as before, the same QR code. We have people from India, USA, Egypt, Brazil, Germany, Saudi Arabia. What else? Kingdom of Saudi Arabia, Italy, Brazil, Bahrain, Germany. Wow, a lot of different countries. We have a lot of people, the Czech Republic, France, Ethiopia. Well, we like having people from African countries. This is one of our topics today will be how to manage cochlear implantation, bilateral cochlear implantation in emerging nations. What are the challenges? And we love to have people interested in watching the ideas of our experts. Okay, well, we have people from Austria and Bahrain, a lot of different countries. Anyway, I think this is the time to start with our roundtable. And let's start. This is going to be like a journey, and we are going to travel from place to place without jet lag, which is a good advantage. And the first flight will be to North Carolina in the United States. And we are here in Chapel Hill to meet Professor Kevin Brown. Kevin is the Executive Director of the Children's Cochlear Implant Center at the UNC School of Medicine in Chapel Hill, North Carolina. He's the Chief of Division of Otology and Neurotology and Skull-Based Surgery, as well as the Vice Chairman of Outpatient Operations and Improvement. Dr. Brown is Associate Professor of Otolaryngology in the UNC School of Medicine since 2014, for more than 10 years. We're excited to have Kevin as a hearing member and one of today's speakers, and he will deal with the psychoacoustics of binaural hearing. Kevin?
Thank you. Just one second here. All right. Can everybody see my screen okay?
Yep, we can see it.
Wonderful. So I thought it was a reasonable introduction to talk about the sort of the rationale for why we feel it is important to have both ears implanted. And for me, this is a significant part of the discussion that I have with patients, that have received the first cochlear implant. They're pleased with how things are going, but maybe they're a little bit reluctant to think about getting the second cochlear implant. And I think helping them understand what those benefits are really helps them make an educated decision about whether they wish to pursue getting a second implant or not. This is our fantastic cochlear implant team. And in general, why are two ears important? And it has to do really with what I think are four major variables. Number one is our ability to determine the direction that sound is coming from. Number two is our capacity to understand speech in a background of noise. Number three is the quality of hearing. It's certainly not as good when you're hearing from one ear as opposed to two. And then finally, this concept of auditory effort, which basically describes the amount of cognitive effort that is being spent to understand what is being said. So with respect to binaural hearing, sound is hitting the ear at different times and at different intensities. That difference is utilized by our brain to accurately compute the direction that sound is originating from. So in this schematic, we have a figure that has a sound source that is on their left side. And if we think about how their ears are going to hear that differently, the sound is going to be louder on their left ear and less loud in their right ear. And the brain can actually use the differences that exist with the amplitude in that sound to distinguish the direction that sound is coming from quite accurately. And this is probably, for most of our cochlear implant patients, how they're utilizing bilateral cochlear implants to determine the direction sound is coming from. But there may also, particularly with the longer Medel electrodes, be a circumstance where they can also utilize timing cues. So timing cues mean that the sound is actually going to reach the left ear in this particular subject a little bit sooner than it is the right ear. And in that circumstance, the brain can also use that difference in timing to distinguish the direction that sound is coming from. These timing cues are predominantly low frequency mediated, which is why the really long Medela electrodes may provide that capacity. Amplitude cues are predominantly high frequency mediated, and that's something that's going to be relatively similar across all implant designs and manufacturers. When we think about speech perception and noise, the perception of speech and noise requires two ears. And the reason for that is that each ear is receiving a slightly different input with respect to noise versus the stream of speech. And the brain can utilize spectral differences, the differences in timing, and the differences in amplitude to better understand speech in this noisy background. There's really three configurations that we consider when we're talking about patients for their speech perception and noise. The first of these is a head shadow condition. This is a circumstance where noise is directed towards the better hearing ear. And in the case when a patient has a cochlear implant on the opposite ear, there is now a more favorable signal to noise ratio in that cochlear implant ear that they can do a better job of understanding that speech that may be occurring towards their front. And high frequency tends to be attenuated more significantly by head shadow. And this is a physical effect. This does not require any sort of cognitive processing. And we use this without even thinking about it every day. And even patients that have one ear or one implant can use this effect. And it's the circumstance where, say, you're in a noisy restaurant or a noisy club, and you're leaning into the person to try and understand what they're saying, you're effectively using your head to block the noise in the environment and improve your signal to noise ratio in the other ear. Squelch is when the competing noise is separated from the signal, such that you're getting different signals to both ears, and the brain is essentially going to use the noise stream and compare it to the speech stream in the other ear. And it's going to subtract the noise from the speech in order to improve the ability to understand speech in that noisy environment. This does require cognitive processing. So in the schematic, the sound is at the front, and the noise is now being presented to the cochlear implant ear, such that the brain has that information to subtract away from the speech stream it is getting in the better hearing ear. Summation is the benefit of signal presentation to both ears. And this is a real simple experiment that we can all do. If you put an earbud in one ear and then you put a second one in, it's louder. It's louder when you have two, but it's not. They're at the exact same volume, but it feels like it's louder because you're processing through both auditory pathways at the same time. And that is something that also requires cognitive processing. Quality of hearing is something that patients that only have hearing from one ear frequently describe as an issue. And really, they describe it as it being an inability to orient sound in their environment, what we refer to as spatial hearing. They have frustration with understanding speech with any noise in the environment. The volume of sound seems reduced, and it actually can contribute to a loss of socialization because they're going to avoid those environments where there's a lot of people around. So finally, there's this issue of auditory effort. And auditory effort is, as I started to describe, an effect that occurs when an individual is only hearing from one ear, and the amount of cognitive effort or strain that they are utilizing to understand what is being said, to discern what is being said, is much higher than it is for somebody with hearing in both ears. And when that effort is high over time, it becomes progressively more and more fatiguing. And a way to think about it is that your brain is like a computer processor. If listening is consuming a lot of that processing power, it leads to difficulty with other related and separate tasks, such as increased effort can lead to errors in speech perception, where you don't realize the context and you think something is being said in a normal fashion. It was actually being said in a sarcastic fashion. There could be problems with storing what is being heard into memory. And if you're trying to do a separate task at the same time, it becomes much more difficult to attend to that second task because so much of the brain's processing power is being utilized to understand what's being said. This is just some brief data that confirms this. This was a study done by the Iowa group back in 2012. And basically what they demonstrated is that with a bilateral cochlear implant, that patients were performing better with respect to speech understanding in noise, as well as with localization. So we can see for the majority of these patients, the white bars where they have bilaterals are better than the darker bars. And similarly, with respect to localization, the white bars, which were their bilateral condition, were performing better with localization than they were with the darker bars. So in conclusion, binaural bilateral hearing with a cochlear implant permits better localization. It provides better speech perception and noise for all three configurations, a better quality of hearing. I also wanted to mention that it may help with auditory effort, in particular if the devices are aligned, which I think Otoplan provides us a unique ability to help accomplish that. And because when people have looked at it with other devices, that really hasn't been the case. And with that, I'll finish. Thank you.
Well, thank you very much, Kevin. This was a very clear presentation. And to start the discussion, after each presentation, we will have a discussion with all our panelists. I would like to ask you an easy question to ask, a difficult question to answer. From your experience, of the 4 items you mentioned, which will be the first one in your rank to convince me that I need a bilateral cochlear implant? Localization, speech and noise, quality of hearing, effort?
Yeah, I think the thing that patients probably are looking for the most is speech perception and noisy backgrounds, because we test patients in quiet environments all the time, but the reality of it is our worlds are not quiet. We're constantly surrounded by noise, particularly in social environments. So I think the one thing that patients are most interested in is being able to improve their ability to hear what their friends and families are saying in these more noisy environments.
Good, and I would like to have the other panelists in the screen and ask them the same question. Do you agree? I mean, Andrea, do you agree with Kevin that the most important is speech and noise?
I think that's definitely important, but I often find when I'm talking with a patient and they're asking, what is this going to be like in my daily life? Comparing it to hearing in surround sound is something that's tangible that they can take home and understand. So I think while speech and noise is important, I think quality of hearing and relating it to something that they understand can be a really valuable tool.
And you, Rahman?
Well, I think it depends. Some patient, speaking noise would be their major concern because in one ear they still can hear, they can have normal life, but the noisy environment is the real challenge for them, and the things would make them more and more isolated. But I think the other benefit of cochlear implant, bilateral cochlear implant, is maybe as much as important for other patients. So I think we should give all the patient all those benefit, and we should not underestimate the benefit of having the extra ear working, because it's not like one kidney working. It's enough for us. It's not like the eye. We can still see with one eye, but not with both eyes. But with the hearing, it's completely different story. I think it's those two together are working in a way that augmenting each other, supporting each other, and we are normal people, and we sometimes when you get blocked ear in one side, we suffer a lot. Imagine if those patients, they are not having real normal hearing with the cochlear implant, and how much they are suffering with one side only. So I think no doubt that bilateral is a completely different life.
That was a very political answer. I mean, you didn't tell me which one you prefer. Anyway, I have 2 questions from the audience. The first one, it's saying it's very interesting talk, Kevin. And if we're considering bilateral CI, should we implant also single-sided deafness? And we opened the can of the difficult decisions. Do you think we need to also implant single-sided deafness?
Most definitely. If patients are appropriate candidates, I don't think we should distinguish between patients that have binaural hearing loss and those that have unilateral hearing loss.
Professor Hagen, you have a question there. I thought you were not going to be in this round table.
I made it finally, fortunately. Hello to everybody. So this was a very convincing talk about the advantages, but the main problem is how can we get bilateral cochlear implantation in most countries? We already heard about the emerging countries that have no financing for this problem. So what is a realistic percentage in your country, Kevin, for all candidates who would be feasible for a bilateral, maybe 10%, maybe 50%?
So all patients that are interested in getting a second cochlear implant and qualify can get it. Our Medicare, Medicaid, which is our state-sponsored insurances, cover it. All of our private insurances cover it. So obviously the only circumstance is if a patient is uninsured. Statistically within our program, and Andrea may have a better number on this, but my perception is that of late, we probably about 2/3 of our patients that are candidates to get a second cochlear implant elect to get a cochlear implant because that's obviously their decision. And there's a lot of sort of variables that contribute to a patient's decision to get a second cochlear implant, namely residual hearing. But I would say about 2/3 now.
Okay, I know. Sorry, go ahead.
I would agree. It's about 2/3 who qualify get it. I think this year when I checked, it was like 30% of our adult caseload this year was second sides.
Okay, I know that Baumi wants to ask a question, but we have another question from the chat. Let me bring this one first, and then we're going to move to the next presentation, and we will keep with the discussions. Baumi, I will come back to you later on, right? So the question for you, Ranjit, bimodal stimulation, how far from the bimodal stimulation, how far from the psychoacoustic aspects you perfectly covered, as he's referring to the presentation by Kevin. So the bimodal stimulation and the psychoacoustic effects.
Yep.
What's your opinion?
Got it. Yeah, first of all, Kevin, that's a great talk. I want to highlight one important point, from Kevin's talk with respect to the bimodal hearing. So one of the difficult tasks for the cochlear implant to process is timing cues. We all know that. The spectral cues are okay, but timing cues is very difficult. The biggest advantage of having bimodal, it ensures better timing cues. So when compared to bilateral electric stimulation and bimodal stimulation, the timing cues are much better. So what's the importance of timing cues here is better speech perception and noise. And what's advantage of better speech perception is noise is less fatigue to the brain to listen to the conversation, less fatigue in the brain to participate in socialization, right? That gives such a more ease for people to socialize. That's more important. The brain fatigue is less. The ease of listening is easier. The attention span is longer when speech noise is better. And that improves the quality of life for them. So it's not just one after another. If you have speech and noise, then that leads to good quality of life because it makes much easier for the brain to process informations. And that's much better with bimodal stimulation because bimodal ensures better timing cues rather than just electrical alone.
Okay, thank you very much. We'll keep discussing, but right now we need to keep our journey. This is going to be the shortest flight today because we're still staying in North Carolina. And we're back to North Carolina to meet you, Andrea Overton. She's an audiologist and adult audiology supervisor at the UNC School of Medicine. She provides expert care and services to patients seeking hearing solutions in the Chapel Hill area, and her special interests include diagnostic audiology, cochlear implants, and auditory brainstem implants. The hearing group, is delighted to have Andrea as one of our panelists today during the discussion and the presentation. She will deal with some audiological considerations of bilateral cochlear implants. Go ahead, Andrea.
Thank you so much for that introduction. I'm going to share my screen. All right. So I thought it would be important to start with a discussion of the potential advantages with bilateral cochlear implantation as compared to bimodal stimulation, and thinking about how we talk about this with patients. So separating it into three different categories: the practical advantages, measured, and then subjective. I think from a practical standpoint, if we're implanting both ears, then we know that we're always implanting the better ear. That's no longer in question. And if we have both ears implanted, then there's never a time that if a patient were to have any kind of equipment malfunction, they're never off the air or without sound, which I think can be a real benefit to an individual. Additionally, I think having the potential for matching technologies, both externally and internally, can be a big advantage, and that's going to be more important for those who are having simultaneous implantation or have a shorter intersurgical interval. From a measured advantage standpoint, I think Dr. Brown went through this really nicely, so I won't belabor it, that we can see an improvement in hearing and noise when sound sources are spatially separated, likely due to the cochlear implants being better at deciphering those intraoral level differences as compared to the timing differences. We can see a reduction in the head shadow effect, improved binaural summation or redundancy, improved squelch, and then of course sound localization. From a subjective standpoint, patients tend to report that it's more natural hearing. So as I mentioned before, feeling like it's kind of a surround sound hearing, and it's a little bit easier, less auditory fatigue, and more of an increased safety awareness. We also talk a little bit about whether it's simultaneous or sequential. So simultaneous indicating a single surgical procedure, sequential indicating two separate surgical procedures. We know that the complication rates are pretty similar across both. And so when we think about simultaneous, oftentimes that's not covered by all insurances. So we see that more often in our pediatric population than adults. And on that note, we've seen that infants who are 6 months and older have undergone simultaneous cochlear implantation, and that's really allowed for the development of the binaural auditory system for those folks. From a sequential standpoint, it does mean that there are two exposures to anesthesia, and that can often mean 2 times the surgical cost. From a hospital perspective, that likely means that there's going to be more profit with 2 surgeries versus 1. But I do think sequential allows for the asymmetric and progressive hearing loss population to receive cochlear implants as that other ear becomes a candidate. And this is really where the bulk of our adult population lies. I do think we need to consider the outcomes for folks who have a longer intersurgical interval. So by longer, I mean much greater than 10 years. For sequential bilateral implantation, we really approach the evaluation and talk to patients thinking about kind of a systematic approach of, is the patient making expected progress with their first side? If not, then we obviously need to address that first. We want to take a look at the status of the contralateral hearing ear. Is it a candidate on its own? Is the patient wearing a hearing aid, or have they ever worn a hearing aid on that ear? And how long has it been since their first device was placed? We also take a look at their bimodal benefit. So does the patient have any? In particular, looking at that in background noise. If they have no bimodal benefit that's tangible in the sound booth, or it's very minimal, that can be used as a really useful counseling tool. And then in 2019, Renee Gifford and Michael Dorman came out with a study that indicated that you could ask a patient whether or not they thought that they would benefit from a second cochlear implant. And that actually was a very highly sensitive measure for determining their outcomes in cochlear implant candidacy and their satisfaction with the device afterward. So that's something that we've incorporated into our practice. Insurance coverage is obviously important. It's not the fun part of the conversation, but unfortunately that can be the reason why someone may pursue or not pursue a cochlear implant. And then I think the coil site location shouldn't be overlooked. That's going to be especially important for folks who really like to use the off-the-ear processor like the Rondo 3, as the microphones are going to be located on that coil site. So having that symmetric is going to be important. From a post-implant consideration standpoint, I think of this in both bilateral mapping considerations as well as just general logistics. From a mapping point of view, loudness balancing is going to be important. So a patient may be comfortable in the unilateral condition, but with the summation of bilateral devices, balancing is definitely going to be needed. We try to match parameters where we can, so things like volume settings, processing strategy, stimulation rates, anything that we can match reasonably, we try to do so. Streaming is definitely easier when you have two matching cochlear implant technologies versus a cochlear implant and a hearing aid, because there can be so many variable platforms, manufacturers, et cetera, for hearing aid. Oral rehabilitation is a consideration. So what I might recommend could be different for simultaneous versus a sequential individual. And then from a remote control and app use, I know this sounds kind of silly, but if a patient is used to having their settings one way and each ear is slightly different, then the app itself will actually look a little bit off and become a little less useful to the patient. So having those kind of mirrored on both sides can be really important. And then from a logistics standpoint, I think it's really important that we determine the appointment length and the frequency. Oftentimes that's going to be determined by reimbursement. So for example, in the United States, Medicare does not pay any additional money for bilateral programming or additional time spent with the patient. So oftentimes there are clinics that will choose to see those patients on two completely separate days, so that they are able to have adequate reimbursement for that. But that obviously brings on a whole host of other issues. I think we also have to consider, if we provide cochlear implants to all patients that could benefit, do we have the infrastructure, the staffing, the booth space, the availability to actually see all of these patients? And then of course, on that same note, do we even have the resources available? As alluded to before, there are a lot of countries that limit the number of cochlear implants per year, and a second side implant may be a lower priority than a first side implant. So it's important that we're good stewards of those resources. So I think in conclusion, in my opinion, there's no question that bilateral cochlear implantation can be incredibly beneficial to patients. I think we're in a really exciting time and uniquely positioned in this group to consider how we can make this feasible worldwide in a multitude of different practices. Thanks.
Well, thank you thank you very much, Andrea. It was very interesting. So you bring up the issue of timing, and before entering into the discussion, let me give the word to Professor Baumgartner, who mentioned before that he wanted to say something. Baumi.
Thank you very much, Javi. Actually, it's my comment because of the bilateral benefit. What we observed, so we did the first bilateral adult implantation in 1996 and the first pediatric in 1997. And the leading benefit is depending actually on the age of life and the etiology of deafness. So the leading benefit for a newborn in bilateral hearing is to learn the bilateral hearing at all. And this is completely different from an adolescent with a progressive hearing loss, or an adult like us with sudden hearing loss, or an elderly person with a very prolonged over decades hearing loss. So all these candidates, depending on the etiology, have a different leading benefit of bilateral outcome. I think this is important at least to state, because it's also important for the different expectations of the bilateral candidates. And this also leads us to the fact that, of course, we need to implant single-sided deafness. We have extremely good experience. This I just want to say as a short statement. Thank you.
Okay, thank you very much. I like short statements and short answers so that we can have more discussion. I will bring you one more question from the chat, from the audience, saying, away from the financial issue, what if the patient refuses the second implant? Is bimodal fitting an alternative?
My answer is yes. I think ultimately we want there to be a treatment option on both ears that's appropriate. And if they can't or are not going to pursue a second cochlear implant, then I think a hearing aid is appropriate to put on the other ear.
Good. Rudolf, you want to ask something?
Yes, I missed the fitting. So in children, I think an argument for the bilateral simultaneous is the possibility to have a shorter fitting. And if we look for reasons to convince the insurance companies the ease of fitting, the shorter period of fitting should be one argument. What's your opinion on this? And my second question, you told us one presupposition is progress with the first side, but we have also cases when we fail with the first side, and what then to do? Doing the second side to try to get at least some hearing?
Okay, for the first question, Rahman, you're the god of the early fitting. What about fitting?
Well, I think we have long experience with the early fitting. So now almost all of our patients, they end up with the early fitting. If not the same day, they have it next day. Children and adult, bilateral or sequential. So in our experience, there is no really any explanation or any need to delay the fitting for the patients. And the other thing also recently we have found that the earlier fitting actually give us a better hearing preservation. And we think maybe the introducing the electricity early to the cochlea will minimize the trauma to the inner ear and actually give you less fibrosis and better outcome. And we publish this one, and it seemed to be a promising future for our patient with the cochlear implant. And I don't think any need nowadays for any delay in fitting our patient because there is no really any evidence that the delay would be for any benefit of the patients. And I'm glad that we were able to convince Professor Hagen with this, and he accepted now. And actually, if we listen more and more to our patient, and we will find that the major concern for them is to wait for a month until they see the benefit of the surgery itself. So
Okay.
I think that would be one of the best things we can do for cochlear implant patient.
Great. What was the second question, Rudolf?
The presupposition was that the patient has success with the first side. But what is with the patients who had low success with the first side? Maybe you hit the wrong ear. So is this an indication also to try the second side?
Andrea?
Yes, I think you have to consider each patient and their etiology. And there are some folks that will implant their poor hearing ear that we don't have high hopes for what that ear could potentially do, because that's the only thing that they're willing to do for their first side, with the understanding that I would have a different expectation for outcomes on the second side. So I think it has to do a lot more with the counseling, and it's not a reason not to pursue a second side, but I think you have to take it case by case and have counseling that's appropriate for each of those individuals.
Ranjit, you agree? You're muted.
Mike.
Ranjit, you're muted.
I agree with her. I completely agree with her. You need to go case by case, and there's no reason why you should not implant the second side if the expectations are very realistic.
One of the things we do in our center is to do bilateral simultaneous. So basically, adult and children, if they do bilateral, you don't know which one would be the best. But in reality, if they become together, definitely they will be better than one alone.
Good. And one of my doubts is concerning timing. Which is the maximum time you can leave between the first and the second? Both in children and in adults. Andrea?
So I think for optimal performance, I think like 7 to 10 years is an ideal amount of time. That's not to say that I wouldn't implant a second side that was 20, 30, 40 years later.
You will not do it. You will not prevent doing it after 20, 30 years.
If that ear had some type of amplification on the other ear, and the patient has a realistic expectation of what's their goal with this. Is this so that they have some sound awareness on the other side? That's very different than if they're expecting it to be, the same exact sound quality and speech perception. So I think it depends on the patient, and it depends on what their ultimate goals are.
You agree, Ranjit? Two important points in this.
Yeah. Go ahead.
The first one is the reason for the second device, even after 20, 30 years. We need to understand from them why they want to get the second implant done, why they want the second ear to be implanted. And if the reason is reasonably enough to achieve, and then we can go ahead. If not, I think we should give them, not discourage them, but just tell them what the facts are, And from our experience, I agree with that 10 years is the optimal time. And we have a couple of patients who we implanted 12 and 14 years. They were non-users of the second device now. So we strictly recommend less than 10 years, not more than that, unless otherwise the patient insists and if the expectations are realistic.
But if it's more than 10 years, because Andrea mentioned that she will not stop doing that if it's more than 20, 30 years, she said, will you do it also?
Yes, we would do it. That's what, two reasons. One, we need to understand why they want the second side implanted even after 20, 30 years, one. And the thing is, that if the reason for them for going for the second device is reasonable enough to achieve, if that target is reasonable enough to achieve, then fine. Otherwise, we give them realistic expectations. And it's absolutely the choice of the patient to decide. And just because they cannot achieve good speech in noise, like, how you do it in simultaneous, doesn't mean that we should prevent them from using the other ear.
Good. Okay,
let's
go ahead, Andrea.
I was just going to give a patient example. I had a patient who was implanted as a little baby, was 20 years old, has one ear implanted, and then had their own child like 25 years later and wanted to get the second side because they felt like they were having a hard time localizing or even having awareness on the other side and were worried about crossing the parking lot with a child. So they didn't have the expectation they would have a whole lot of speech understanding, but for them, that was a huge part of their quality of life. So I think in the right circumstance, it's reasonable.
Okay, let's keep with the discussion after the next presentation because we have to continue our journey today. And the next flight is taking us from the US to this Kingdom of Saudi Arabia, to Riyadh. And here we are in Riyadh with Professor Abdul Rahman Hajar. Professor Hajar is the president of the Saudi Oral Society, ENT Society, as well as the Arab Academy of Otology and Cochlear Implants. He's professor at King Saud University and director of the King Abdullah Ear Specialist Center. Professor Hajar is also the member of Corlas since 2018, and the hearing is honored to have Professor Hajar as one of our active members in our group. He will present a novel approach to bilateral cochlear implants in adults that he calls ABCDS initiative. Rahman, can you tell us something about what is the ABCDS?
All right. So first, thanks a lot for inviting me, and I'm really enjoying this kind of a meeting and discussion, and keep me always updated and interested in this field. And in reality, that Saudi Arabia is one of the countries which is adopting the United Nations sustainability goals and trying to make everything with low carbon emissions and better for our grandchildren and for the futures. So it's something that becoming of interest of everyone in Saudi Arabia. And we're trying to see how can we move to the green environment, making everything green. And almost every hospital now moving to green hospitals and green OR. And we also moved to this green cochlea idea in our center to see how can we do better surgery, safe, easy, with the less chance for any trauma to the patients, to the cochlea, and less carbon emission. And we have found that a lot of things we can modify in our technique that make surgery easy, fast, and enjoyable with less carbon emission. Including the general anesthesia, and we to move from anesthesia because it's almost 20 times carbon emission compared to the local anesthesia. So it's a major issue that could affect our environment, our economy, and futures. So we come always with the initiatives, and one of the initiatives is the ABCDS initiatives, which basically adult, bilateral, conscious sedation, day surgery, and same-day fitting. So I hope you're going to enjoy these initiatives, and we hope we're going to continue with more and more initiatives. I was lucky to be part of this roundtable for the first meeting, and I did enjoy it, and it comes with a lot of ideas, and I'm happy as well to be in part two. And even in 6 months difference between those two meetings, we thought of modifying a few things in our practice and come up with ideas that we could share it together and enjoy it in this meeting. So in the last meeting, we look at all these important points when we are talking about bilateral cochlear implants. And one of the major concern was the balance. And we have a lot of discussion on this in the previous meeting, which I suggest everybody could have the chance and look at it again. And also was a major concern of hearing in those cases and how long it would take until they would reach to the stable map. And all of these would be solved by the early activation. And also we discussed the general anesthesia and the major impact of general anesthesia in children as well as in adult. And we know it has a lot of warning and effect on brain development in children, and also in elderly or adult in general, where they could have a lot of complication with the general anesthesia, with the deliriums and major cognitive functions. So all of these are major issues that we need to avoid them, and this is part of thinking always of green cochlea to minimize all the trauma, all the effect that we do to our patient during surgery. So instead of doing step one forward and two step backwards, adding more trauma to the brain and affecting the cognitive function, we try to minimize all these issues by see how can we do the surgery fast, easy, with the minimal effect. So one of the things I would like to share with you here is this experience with the anesthesia, local anesthesia. We used to go with the needle and go all around the ear, freeze the ear for this local anesthesia. But our anesthetists come up with this wonderful idea of localizing the brachial plexus with the ultrasound and go with the small needle and inject just few millimeter around the nerve, which by this minimize the trauma, minimize the effect of anesthesia on a patient, and give it a longer time for me, rather than every few minutes I put another local in the ear. And this is one of our patient that he had bilateral simultaneous cochlear implants under conscious sedation, and we wake him up just repeating his name, and you could see how much he was excited with this. Extremely excited. He could not believe that immediately, just waking up, he's able to hear, with a lot of tears from him and from everybody in the room. So this is one of the things that we are actually promoting. The earlier, the better. The earlier interventions, the earlier the activations of the sound processor. We published this paper more than 4 years ago, which is feasibility of the surgery cochlear implant under conscious sedation with the same day fitting. And since that time, we're offering this to all of our patients, and a lot of patients, they were extremely excited and happy to go for it. And we thought of getting one step closer, and this by going with the simultaneous adult cochlear implant with the conscious sedation. And we published this paper just recently in October 2024, adult simultaneous cochlear implant with local anesthesia. And you could see here, this is the early cases. We look at them. 6 cases with no comorbid disease. We used to do it for any patient with comorbid disease this conscious sedation and local anesthesia and same-day fitting. But nowadays, we just offer it for anyone who's interested. So those are the first few cases. So we publish them. And those cases with the severe hearing loss, so they're still using hearing aid. And we follow them for a year. And we send them a questionnaire to ask them about their experience. And you could see here that almost all of them, the 6 patients, they prefer the activation immediately compared to the hearing aid. Like they were able to hear with the cochlear implant better than the hearing aid. No one have any problem with the balance, none of those 6 patients. So those 2 out of 6, they prefer to delay the surgery, and the 6 of them, they did use the cochlear implant device more compared to the hearing aid. And 5 out of 6, they recommend to go ahead with this surgery under local anesthesia. So as you could see here, that most of our patients, they are extremely excited and happy to go with these options. And we're getting more and more patients interested in this. And I think well, by giving patient more options, that would be really the best because you will be surprised that some of them will be interested in local, some of them will be interested in general, and some of them will be happy to go with bilateral simultaneous under conscious sedations. So this is another possibility and another options. And I think as otologist, we need to work like an ophthalmologist. And you can see with ophthalmologists, they offer everything to their patients, either the eyeglasses, lenses, laser. So you will be surprised how many one still interested in wearing eyeglasses in spite of having all those advanced lasers. So the same thing, I think, in our practice, that we need to give patient all these options. And you'll be surprised at how much patient will be interested in bilateral simultaneous cochlear implant under conscious sedation. So answering your main question, that doubling the sound, doubling the benefit, I think the answer is no. I think doubling the sound quadruple the benefit because in many aspects there's a huge benefit in bilateral cochlear implant because the cost definitely will go down with the high volume, definitely the low margin, so be more and more low cost on a patient, and the patient will be having almost close to normal by having bilateral cochlear implants. And the other thing we also should not underestimate is the detachment of people if they are not using the cochlear implant from their environment. So having bilateral cochlear implant will keep them on air almost 24 hours. And we should not underestimate those devices, issues that with the batteries, with the maintenance, and so on. So having both ears working and one is working and not the other one during some issues, that would be another extra advantage that really worth having bilateral. And I'm sure patients themselves would be more advocate for bilateral cochlear implants. And in our centers, it's almost now becoming almost a routine for bilateral cochlear. In children, almost all of them bilateral simultaneous cochlear implant. And the adult, they become more and more interested in cochlear implant. Before they were hesitant, not because of the surgery itself, but rather the general anesthesia. And some people, not only them, but also the relatives are against general anesthesia surgery. So they under a lot of pressure from their relatives not to go for surgery. So I think by giving all these options to the patients, I'm sure a lot of them will be interested in having the cochlear implant and having bilateral cochlear implant. At the end, I would like to welcome you all to Saudi Arabia in our international conference. And you could see here how we moved from the sand color to the green color of everything in Saudi Arabia. Thank you.
Okay, thank you very much, Rahman. So let's have a discussion, a few minutes of discussion. I have a question from Professor Hagen. I have a question in the chat, but I want to ask first of all, a question to the surgeon in the panel, Kevin. Local anesthesia, yes or no?
Yes, if patients are interested in that option and if there's a sufficient medical reason for doing so. Honestly, I'd say I haven't had a circumstance where I've needed to do it, but I'm not unwilling to if the right circumstance comes around.
Well, I have the same feeling, Rahman. I need a general anesthesia even for a haircut. I don't like local anesthesia. So I understand your approach. I mean, it's less than general anesthesia, but for patients that do not have a problem with general anesthesia, do you also prefer local anesthesia?
Well, actually, it's not me. I prefer to do cochlear implant, but tell you the truth, patients themselves are actually excited to go for local anesthesia. And this is the things that you'll be surprised that some people are hesitant to go for cochlear implant because of general anesthesia. So I
Really?
think yes, definitely. Okay. I'm not sure outside, but in Saudi Arabia, it's a major issue always and also we have seen some elderly where they have a lot of mental problems after they go for hip replacement under general anesthesia or any other general anesthesia causes. So it's a major issues nowadays is this general anesthesia effect on the brain. And also not to underestimate the carbon emission in general anesthesia. It's a major issues and every hospital is trying to cut down the carbon emissions. And if we look at it on the medical service, we will be the 5th country in carbon emission. So something we should always consider it.
Rudolph, general local. You're muted, I think.
If the patient is suitable, you can perform it in local. And I understand the argument that in patients, in elder patients, maybe the decision to have it in local is better than in general. But my question is, how many patients do you already perform in local anesthesia? And in how many of these, this argument missing general was really the most decisive thing? And the second question, you have this wonderful humanitarian project at the border of Turkey. Do you also perform the surgery there in local?
A short answer, please, Rahman, short answer.
Okay, for Saudi Arabia, we do this for adult, and most of our patients are children. So the number of adults actually is like 20%. And this is why we don't have a large number, but I think we are almost close to 70, 80s. And none of them that we really regret not to do them. At the beginning, we convert a few cases from local anesthesia to general anesthesia, but I think it's part of our training at the beginning, and everything is difficult at the beginning. But nowadays, we found it extremely, extremely exciting for us as much as it's for the patient. For the humanitarian reality, it's not. It's most of them are children. We are doing them, so we are not yet in the era of local anesthesia for children, but I hope it's going to be soon.
Kevin, do you have on your daily practice, do you have this pressure or request from the patients for local anesthesia? Because I don't have them. I mean, my patients don't ask whether they can do it under local. It looks like it's a cultural issue.
Yeah, there is a very, very rare patient that will come in wanting or considering local anesthesia. But for the most part, and this actually extends to other operations, like I offer doing local anesthesia with a touch of sedation for stapedectomies. Every single one of my patients almost uniformly is like, I want to be asleep.
Yeah, well, I understand that. I have a question from the audience, which affects the audiologists in the panel. Well, the question says, in bilateral sequential fitting, is if the initial fitting in the second ear should be similar to the first implanted one, according to the patient response in the second ear, even if the fitting in the first one fitting was very comfortable to the patient. Well, basically, what I understand is whether the second fitting should be the same as in sequential as the first fitting, or shall we do a different fitting, or maybe ABF is an option. Do you want to answer, Ranjit?
Well, It's an interesting question. But we don't have to. The most important is the fitting is based on the certain comfort that has been perceived with ear-specific stimulation, right? So that sometimes when it comes to sequential implants, there are a lot of things that can definitely alter the level of perception, including the frequency allocation as well as the loudness level of that. So definitely, in my opinion, I wouldn't definitely do exactly the same levels as what we do it for the first side. But if you ask me the method of fitting, whether if you do the ABF on the first implanted side and you also want to do the ABF on the second one, yes, that makes sense. But not necessarily that you need to exactly do the photocopy of the first thing.
Andrea, a short
important
answer.
Agreed.
Yeah.
I would try to match parameters, but I would not match stimulation levels. I would use ESRTs to set.
Okay, let's finish our journey today by the last jump from Saudi Arabia to India. And we came to Chennai, in India, to meet Professor Ranjit Rajeswaran. Ranjit is the director and chief audiologist at the MERF Institute of Speech and Hearing of the Madras ENT Research Foundation. He has co-developed this center as one of the most sophisticated places to treat patients with hearing loss. His special focus is on hearing restoration and hearing implants. And we are very proud to have Ranjit among our distinguished hearing members and our last panelist today. Ranjit, you will deal with the challenges of bilateral cochlear implant in emerging nations. We have quite a large audience right now, and a lot of them are from emerging nations. So don't make it too long, and we will have more time for discussion. Go ahead.
Yes, thank you, Javier. And yeah, this is one of the shortest presentation I've ever made in my life. This only has 4 slides, right? So I'll just dive into the topic first. The topic is bilateral cochlear implants, challenges in emerging nations. Now, I'm giving this talk with one big advantage of working in different emerging countries because we work in India. We also developed cochlear implant programs in Sri Lanka, Bangladesh, Bhutan, and Nepal, and also in 1 or 2 countries in Africa. So with that experience, I would like to quote some of the interesting facts that we observed. What are the major challenges in developing nations? But first, let's come to India. The first cochlear implant in India was started in 1994. By 2023, we had close to 40,000 patients implanted. So the cochlear implant, and most of them are unilateral. More than 95% of the subjects who receive CI in India is unilateral. Only 5% or less than 5% are bilateral. This is an arbitrary figure based on the statistics that we could get to try from the company. So one of the bigger problem in the emerging nations have is they don't have a registry, hearing registry, to exactly estimate the percentage of the stats. But however, if you look at the growth of cochlear implant in India is 5%. On an average growth is 5% every year. But when it comes to the bilateral implant, I would like to show one of the survey which was published last year. This was a survey on looking at the challenges in cochlear implant among the otolaryngologists in India. So if you look at the survey, majority of them have said cost is the biggest reason why many people could not receive cochlear implant. But by the way, this is a survey for unilateral implant. This is not a survey for a bilateral implant. But if you look at the last 3 of this, the issues with related to the maintenance was least rated. So people said maintaining the device was not one of the major reasons for people going for a cochlear implant. But when it comes to bilateral implants, the reasons might be the same, but the priorities vary here. Now, let me explain you how things work in India. We have 2 kinds of funding. One is the government funding, which is provided by both the central and the federal government. We have cochlear implant funding. But both the governments only fund for unilateral implants. They don't fund for bilateral implants. And they only fund children. They don't fund adults at all. So adults in India do not have any funding from the government or any insurance scheme. And majority of the implants, in India are because of the state funding. So if you look at the growth of cochlear implant program in India, till 2012 or till 2013, our growth rate was less than 1%. Less than 1%. After 2013, once most of the states implemented the state funding program, the growth rate was close to 7 to 8%. So now majority of the reason why people go for cochlear implant in India is because the government is willing to fund for them. And if you look at the self-funding market here, the cost of implantation is quite high with respect to the per capita income. And more interestingly, the cost of maintenance of the hearing, and that's exponentially going up for them. And with respect, with specific reason to the poor socioeconomic status, poor hygiene, there's quite a frequent wear and tear of the devices, which is very difficult for the patients to maintain. And the last and also very important point is upgrades. You know, the implant companies phase out their processes once in 5 years, and the patient has to pay from their pocket to upgrade. The cost of upgrade is very close to a cost of an implant by itself. So this is a very important reason, and especially when you wanted to upgrade for bilaterals, when you want to maintain 2 hearing is much more expensive than maintaining 1 hearing. So one of the major reasons for a challenge for bilateral cochlear implant is the cost. And if you look at the insurance coverage, private insurance coverage, the private health insurance in India do not cover cochlear implant. And there is no antenatal insurance covering cochlear implants in India. Absolutely no. And the NGOs were the funding agencies. So the funding agencies, we have limited funding, but all those limited funding is restricted only for unilateral implants. They're not for bilateral implants. So by far, the point is there is no means of getting funding for bilateral implant in India, unless otherwise the patient has money from their pocket. Right. And another major challenge was awareness. So awareness for cochlear implant is one major problem. Other major problem is awareness about bilateral implant itself. Not many professionals are convinced about bilateral implants. This is a true fact. Even when they give the expectations, when they counsel the patients right from day one, they don't even counsel for bilateral implants. They only counsel them for unilateral implants, which is a fact. And awareness about bilateral implants, the benefits of binaural benefits among the patients is very, very poor. So this is one of the main reasons that, you know, the patients are, the parents are mentally prepared for unilateral implant. So for them to convert the mindset from unilateral to bilateral, sequential or simultaneous, is very difficult. Another major reason is accessibility to rehab centers. Now, because of lack of rehabilitation, the outcomes are very poor. And also the lack of trained rehabilitation specialists. And you know, this is very important because rehabilitating a child with unilateral implants simultaneous is different from rehabilitating a child from, bilateral sequential implants. Right. And when you don't have a very skilled, trained professionals, and that too, the accessibility of these professionals are very limited, the outcomes are reduced. Now, what happens when the outcomes are reduced, the motivation goes down. The parents are not motivated when the outcomes are very poor. Now, above all of this, one of the most important point is the age at first implantation. The average age of a child to receive the first implant in India is between 3 to 4 years, which is way above compared to many other developed countries. This is simply because we don't have universal newborn hearing screening program to pick them very early and intervene them early. Now, the reason why the bilateral sequential implants are not happening, even in some subjects, those who have the money to do an implant, is because when you implant the first device at the age of 3 or 4, the outcomes are very limited, very poor. So in this condition, the advantage of having a sequential bilateral implant to match in par with the binaural benefits is nearly impossible. Another interesting fact which we lately identified, even in centers where we do bilateral implants, they don't have the infrastructure to measure the binaural benefits. The measures for localization abilities, the measures for speech perception and noise, those facilities are lacking. So there is no enough data even to convince the patient or to show to the patient, to the government, that binaural implants do more benefit than unilateral implants. Another reason challenge was etiology. So in India, we have a high incidence of anomalies of both cochlea and cochlear nerve. Now, this is another important challenge for going for a bilateral implant. And the social stigma. The social stigma is, it's a cultural effect where wearing a device, hearing aid, or wearing a cochlear implant is considered as, a stigma here for various reasons. And when you want to tell them to go for bilateral implants, it adds more stigma to them. So stigma is one of the major reasons why most of the patients don't prefer to go for bilateral implants or even for the unilateral implants. Now, this is an interesting effect that what we have found. So we have quite a few patients who receive bilateral sequential implants, and just because they received the implants at a little later age, the perception of sound in both ears was totally different. And because of this difference in perception of sound, they become a negative counselors, negative role models for the other patients to seek for the sequential bilateral implants. So fundamentally, there are too many issues here. So the major reason is the cost and maintenance of the device. The second problem is a late intervention because of lack of universal newborn screening program and awareness. And third one, when we don't have the local data on binaural benefits to convince the policymakers to promote or to provide bilateral implants through this funding scheme. The reason why I have to highlight this point is, unless otherwise the state and the federal funding scheme implements a bilateral program, it's very difficult for patients to undergo bilateral implants, since more than 80% of the patients, those who received cochlear implants in India, are only through the state and central funding scheme. Thank you.
Okay, thank you very much, Ranjit. I don't understand. I mean, stigma for a bilateral cochlear implant is much more than stigma for a unilateral cochlear implant. I mean, you have something, and this something is just there.
True, I completely agree with you. But to a certain extent of the population, we have more deep-rooted cultural beliefs and norms, right? And they really need, and it's very difficult even for us to understand why. It's very difficult for us to understand why. But some of the families decide not to go for a bilateral implant simply because they don't want it to get the other side exposed that the child has got a hearing problem or has a hearing problem. Another reason which I forgot to mention is most of the patients doesn't go for bilateral implants thinking that at some point of time they will have a stem cell implant which can be used. They say they want to preserve the hearing for the other side for the future technology. Even if you explain to them, it's not the technology, it's the brain that makes a lot of benefit.
Okay, that was one of my questions, but I have Professor Hagen. Rudolf, we are very short of time. A very short question, please.
So this was a very sad talk, in my opinion. So can you estimate the percentage of people who should have a cochlear implant in India and do not receive it?
Would say 95% of the existing cochlear implantees needed another implant. Mm-hmm. For the simple reason, India is one country where noise is civilization. And this is a place where they need to have bilateral implants.
But in general, which is the percentage of the whole population? You mean deaf people who should have a cochlear implant, and how many do really receive a cochlear implant in India?
Well, it's less than 5%.
Is it 1% or 2% meanwhile?
So if you look at, Rudolf, if you look at so far, less than 5% of the people have received cochlear implants on the other side. It's sequential or simultaneous.
No CI at all.
And You mean no CA at all?
No, CI at all.
CA at all, yeah.
Yeah.
Yeah. And
Well,
all these 5% of these patients are self-funded patients, not through the government funding.
Mhm.
Well, according to the WHO report on hearing, less than 10% of the people in need of a cochlear implant receive one. I'm not talking about two, receive one.
Mhm.
And that happens also in Europe and the United States and all over the world. So maybe it's 5% in India, but it's not that huge in the other countries in well-developed world. Would you all agree that, I mean, I'm imagining now the people from emerging nations connected to this roundtable and hearing us talking about two cochlear implants. And would you agree with me that bilateral cochlear implant should be the rule as long as unilateral cochlear implant is not stopped because of people having two implants? I mean, giving two implants to one patient is not good as long as this second implant could not be used for another person, for another child. Would you all agree that we should go for bilateral, but first of all, we need to go for unilateral to all patients that request one, that need one? I don't know if I made me clear.
Yes, I think it's clear, but in my opinion, that we should not compromise one because someone who's interested in bilateral. But at the same time, we should not stop fighting for everybody to hear with bilateral hearing aid. And I think we have an issue in Saudi Arabia like this long time ago, and we solve it in a way that we decide that cochlear implant should not be part of the insurance companies. It should be part of the government treatment for those patients as much as the same for cancer, as much as for the vaccine. Is something like should be ABCD treatment for everybody. And I think we were in Saudi Arabia successful in this regard to the extent that Saudi Arabia is considering cochlear implant part of the humanitarian and support and first aid to other people. So I think we need ourselves to show everybody how important the cochlear implant, how important is the hearing for everybody's. And I don't think any country, if they understand it clearly, they will be against bilateral cochlear implant.
No, they will not be against Rahman. I agree with you, but the problem is resources. I mean, Ranjit mentioned that if we don't have the money, we don't have the money. And I have a sentence from Luis Hofmeyer from South Africa here and in the chat. Agreed. One for more is better than two for few. And that's the idea I wanted to give. We are dealing with bilateral. We want bilateral. But please start by one and let's move on the scale. Ranjit, last comment. We're out of time. Ranjit. Oh, it's frozen. Ranjit?
Can you hear me?
Yep.
Yeah.
Yes, we can.
I think the video is freezing. Hello?
Yeah. Now, try again. Okay, well.
Yeah, now I can hear you. Can you repeat the question quickly?
Yes. No. You were raising your hand. I thought you were raising your hand.
Oh yeah. Yes. Oh no. Sorry.
Very short comment.
Yeah, this is just a small misunderstanding of my Rudolf Hagen's question. I thought he's asking for bilateral. So to answer your question very clearly, with respect to even an implant, it's less than 0.5% in India. That's the realistic
1%.
thing.
Okay.
Less than.
Okay. Well, we've been almost 1.5 hours dealing with bilateral cochlear implants. I think we need one more part. We need part 3. So this is a suggestion for the hearing members. We want to discuss a lot of things about this topic. I think it's obvious that bilateral cochlear implants are better than unilateral. That's no question about that. And at the beginning, we were asking whether double cochlear implants will double the benefits of one single CI. And now we see that they don't double the benefits. They bring them 4 times higher. They quadruple the benefits. We also know that going bilateral early may bring more audiologic psychoacoustic benefits. We've learned that long inter-implant intervals may not be as detrimental as we used to think and should not be considered an absolute contraindication per se. They don't represent the ideal situation, but if we focus on realistic expectations, they can still be considered an option. Individualization should be another conclusion of today's roundtable. Remember to keep always realistic expectations from your patient. And finally, keep in mind that there are many different ways to approach the same problem. Always offer the patient as many options as possible. I'm not a very heavy fan of local anesthesia, as I said before, but local anesthesia may be an option even for bilateral simultaneous cochlear implantation in adults. And same-day feeding is another option, which is gaining momentum over the classic 1-month feeding we are all doing. In my personal opinion, and I think it was the general agreement from all the members of the panel, bilateral cochlear implantation should always be preferred as long as we have all patients in need of cochlear implants with at least one device. In other words, bilateral cochlear implantation is ideal when the second implant does not mean another patient without the first implant. And the economic issues are a big disadvantage in emerging nations, and we should overcome this. We're almost out of time. I just want to thank you all for your attention and participation. And before closing, let me mention some practical issues. At Hearing, we would love you to visit our webpage at www.hearing.com. And there you can find tools like our hearing preservation calculator, the hearing counseling platform, the electroacoustic fitting tool. And we have recently updated our quality standards, including the children and adults quality standard, which are more concise. And we are now working on the quality standards on older adults. The format now is more concise and easy to read. And one of our basic pillars at Hearing is the Hearing Boost. The Hearing Boost is our educational platform, which basically is designed to train more people, and it's a learning management system that may be used for all of you. And you can find it in the Hearing webpage. There you will find certified courses. These roundtable programs, all of them are recorded, and you can find them there. So if you want to go there, we'll be very happy for us to have you there. And you can request accreditation for this roundtable that was mentioned at the beginning. You can get a CPD accreditation, which is good, especially for the young people. The procedure will take some time to complete, but in about 6 weeks, you will receive 1.5 points for the hour-and-a-half duration of this roundtable. And finally, we are a very active group. These are the conferences that we are planning to attend as a Hearing group during the next year, from Chennai in India, Frankfurt, Rostock, Naples, and Kuala Lumpur in November. So as you see, we are still very active and trying to keep pushing the world of hearing implants. Please send us all your doubts, questions, or comments to www.hearing.com, and we will be more than pleased to contact you. We hope to see you soon, live, in real life, and we'll hope to see you in the next roundtable. And meanwhile, have a wonderful Christmas season, and goodbye. Thank you very much.